GRACE, the global resource for advancing cancer education, is pleased to provide the following presentation on radiation approaches for localized non-small cell lung cancer by Dr. Quynh Lee, Professor of Radiation Oncology at Stanford University in Palo Alto, California. Dr. Lee spoke at the GRACE Non-Small Cell Lung Cancer Patient Forum in Seattle in September of 2009, a program supported by OSI Pharmaceuticals and Swedish Cancer Institute.
Early stage lung cancer, if the patient can go through surgery, that's the treatment of choice. Unfortunately, we have a small population of patients who cannot go through surgery. So then the question is there any things that we can do for these patients? And in traditional radiation treatment with the olden day where we really couldn't visualize the tumor very well, we treat the patient through to 6 or 7 weeks of radiation, the results are not that good. We're talking about 30% cure rate in this population. This is a frail population we're talking about. But now we have new technologies that are emerging, and so the question is, can we use these new technology to change our pattern of practice and to improve the care and results of these patients? So there are some advances. You've heard about the PET-CT, and the PET-CT allows us to diagnose the cancer earlier and hopefully at earlier stage. But we now, and I'll show you some pictures that the tumor moves with the lung, as you've heard before. And when you breathe, the tumor will move, it will spiral, it does a lot of things. And with us just focusing the radiation field in one spot, it doesn't help. We didn't take care of the tumor motion in the past. Now we learned that we can do that with the new radiation, so we can actually aim the radiation much better. And we actually have new softwares now that allow us to improve the radiation delivery and new hardware that we can image the patient while they're on the table to look at tumor motion and where the tumor is. And so that allows us now to give the radiation more accurately. This is the first linear accelerator that ever built in the world. It was Stanford University in 1956. As you can see in that picture, since then we've gone a long way. And these are new linear accelerators, and we use them to deliver the radiation, to generate the radiation. And these are new linear accelerators that are out there. All of them have ability to image patient with CAT scan or chest X-ray. So now we can see the tumor. In the olden day, we treat the radiation through and through, so front and back. So you see that the radiation beam traverses a large area of the lung. Now we have ability to just focus the radiation around the area of the tumor, so less radiation to that area of the lung, so less toxicity to the patient. As you can see here, here's an image rendering of the lung of a patient. Actually, the blue are the bronchus, the alveoli of the tumor, and the tumor is actually in green here. It's hard to see, but you can see the tumor moves with respiration, so we have to take that into account when we do the radiation treatment. And with the PET scan, you can see that this is the location of the tumor in inspiration. This is the location of tumor in expiration. So you can see that when you take a PET scan, we lay on the table for 45 minutes or 20 minutes when we acquire the PET scan, you can see this blurring approach. So if we treat this whole region, that's a lot of lung for us to treat. So there's a way now that we can do this. We can place the patient on, this is what we call 4D CT PET scanner, and we put a block on the patient's chest wall. And if you put your hand on your chest and you take a deep breath in and out, you can see that your chest wall will move with respiration. And so we use this as a surrogate marker to look at the respiration pattern. So based on that, we actually can acquire CT images, and this is reconstruction of CT images that we acquire during the respiratory cycle. So we can actually see where the tumor is doing the respiration pattern. But now we can do the same thing with the PET-CT. So now we can accurately target the tumor much better and sparing more normal lung tissue. Other ways people are doing that is they can actually put a frame, kind of a chest plate on here to minimize your respiration. So your respiration will be a little bit shallower during the radiation treatment, but then you treat less lung. Or you can put a fiducial into the tumor and track the tumor. Also, during the radiation, we can rotate, changes the leaf. So the radiation deliver up in the top of the linear accelerator. And these can be changed during the radiation treatment while we're moving the beams around the patient so we can conform our radiation dose better to the patient. So let's go back to what we call this new terminology, which is stereotactic body irradiation. We learned that from brain tumors. A patient will have brain metastasis. We know that we can give a big dose of radiation to these lesions many years ago, and because your brain doesn't move within your head, these tumors are fixated, and in addition, we put a frame on in order to best target that. We know that we have a good control rate with these brain metastases. So the question now is, if now we can account for motion for the lung tumor, can we do the same thing for the lung tumor? And that's where the SBRT field comes from. So again, as I mentioned, the standard treatment for early stage cancer is still surgery, but many patients cannot tolerate surgery, and the results of dose escalation study using the conventional radiation therapy has been disappointing. We only have about 30% survival rate for these patients. So this is an emerging promising option that we have for these patients. And what is SBRT? So it's this highly focused radiation concentrated on small tumors, and I emphasize only small tumor at this stage, and we give low dose to the surrounding tissue. It's a single or few treatments, and it's big dose for treatment, so it's also make it a little bit more convenient for patient. It's very precise delivery, and we use all sort of image guidance that I've shown you before in immobilization technique in order to accurately target the tumor. And as I mentioned, this is because we learn from brain tumor and we're trying to see whether we can apply it to lung tumor. And so we have a lot of phase 1 dose escalation studies gone out throughout the world as well as in this country. We can treat it in one fraction, we can treat it in 3 treatments, or we can do it in 4 treatments. Most of SBRT treatment is either between 1 to 5 treatments in the patient spread out between 1 to 2 weeks. And here's the result. These are while we're learning how to treat these patients, what dose to give. We do these studies and we try to figure out what the results are from these studies. So based on this, you can see the control rate in the patient. Again, these are early compared to surgical series, but it's promising 2 to 3 years, anywhere between 80 to 90% control rate for these patients at this point. So this is an example of patient who got treated SBRT. So you see the tumor melted away, but we do see changes in the lung. And we need to follow these patients very carefully because we don't know what the late outcome side effect for these changes that we see in the lung. This is data from the Japanese consortium study, and they show when they pull the data together from many hundred patients that have been treated in Japan, they show that actually what we call BED, or biologically effective dose. The higher the dose, the better for the control rate for these patients. They also have a group of patients that they didn't want surgery. For an operable patient, their outcomes are quite excellent as well. So what are ongoing study or completed study right now? So for patients who are inoperable, so in situations where it's very dangerous to have treatment for the patient in terms of surgery, if the patient cannot tolerate surgery, then there are some of these studies that are going on or have just completed. This is a Japanese study looking at 100 patients randomized between surgery and radiation, and the result will be available in 2010. There's a space study, which is a Scandinavian consortium study. Again, look at conventional radiation versus SBRT, and hopefully that will be completed as well. There's an RTOG, cooperative group study, an early report that's just been completed, showing that very minimal toxicity and excellent control rate, about 96% at this point. Go into the operable patients. I showed you before the Japanese pulled their data, and they're showing that for people who can tolerate surgery, have physiologic ability to tolerate surgery but refuse surgery period, they do have a subset of these patients, and at least their result at this point is quite promising. This is the data from the SBRT compared to surgical series, about 80% survival. Surgery is still the standard of care for these patients, but there are randomized studies to take a look at whether SBRT can yield similar results as surgery. And so this is a study that are ongoing through RTOG. It's a phase 2 study looking at outcome for these patients. There are 2 randomized studies. One of them is activated. The other one is about to be activated. One in the Dutch group, and the other one has been activated, led by MD Anderson. And these studies that we're working together with the surgeons. And patient will be randomized to either surgery or SBRT. The main issue that I want to raise is that SBRT is not the standard of care in this population right now because we don't really have late data, long-term outcome data for these patients, and we don't have the late toxicity data. And that's why it's very important to do the SBRT on clinical trial, because we need to learn about what's going on with the late radiation side effects and also outcome. We do have, in our study, we do track the respiratory function of patient receiving SBRT, and we are not affecting patient respiration. But we do learn, though, that there are certain locations that is not very feasible for SBRT. Those are the locations very close to the central airway because we cause more toxicity when we have those locations. So the lesions we're comfortable treating in the periphery. We do, however, make sure that we need to take care of the toxicity because we give these big doses like this, and we just use beams that go through and through, we can have toxicity, skin toxicity that look like this. So one have to be very careful learning about new side effects of SBRT. So in conclusion, SBRT is a promising treatment modality for early stage non-small cell lung cancer patients who are inoperable. Early data suggests that it may also achieve high local control and survival rate in operable patients, but we need randomized study to prove that.